Audio Jungle.
Hello, my name's Penny Tuffin and I'm an Advanced Practice Pharmacist in Palliative Care, and today we're going to be talking about the management of constipation in people with palliative care needs. So what is constipation? Constipation is defined as the infrequent, difficult or incomplete bowel evacuation, which may lead to pain and discomfort. And it means different things to different people. Different people will focus on, for instance, the frequency, how they haven't been for 2 or 3 days. Other people will focus on the form and the consistency, so whether it was large, whether it was small, whether it was soft, whether it was hard. And the need to strain is something that people will bring up as well in conversation. So it's important when we're talking to people about constipation that we ask all of those factors so that we can assess whether we believe that they are constipated rather than just taking one element of the description that they may offer. Normal bowel habit varies in people. Some people go every day, some people will go up to 3 times a day, and some people will only go 3 times a week. So it's important to get that history and find out what is normal for that person. Constipation is characterised by a slow gastrointestinal transit, and by having that slow transit, it actually means that more water is absorbed out of the faeces into your body, and so therefore the faeces becomes much harder. It's also characterised by a disordered rectal evacuation, so the needing to strain when defecating, and that can be quite a common symptom, particularly as people get older. In palliative care, constipation is a very common symptom, and it can be a long-term issue for these people. It can cause a high level of discomfort and also a high level of embarrassment for people, and can actually mean that they don't go out during the day because they're concerned about the fact that they may hopefully need to defecate at some point. So it's a very distressing symptom, both physically and emotionally for people, and will affect the patient and their families. The stress that constipation causes should never be underestimated. It is a very real and difficult symptom for people to manage. There's lots of contributing factors, particularly for people with advanced disease. Generally, they are eating and drinking less. They also undertake less exercise, and their disease state can also have a direct effect on how their gut is moving and their bowel is moving. Medications that they're taking can be constipating. There's lots of medications we use for managing symptoms that can cause constipation, and when added together, they're going to make the issue worse. Hormonal factors can influence constipation, so for a lot of hormone-regulated disease states, that can be an influencing factor. For patients who have spent a lot of time vomiting, they can become dehydrated, and therefore it becomes much harder for them to maintain their hydration in their gut and their bowel, and so become constipated. Electrolyte disturbances play a large part in constipation, and particularly high calcium levels are something that a lot of our patients will suffer from, and constipation is a symptom that they may have high calcium. Neurological factors are also important, particularly for innervation to the gut and the rectum. So all of these issues must be considered when we're trying to work out the influencing factors in a patient with palliative care needs who has constipation. As I mentioned, a lot of medications we use for people with palliative care needs can influence and cause constipation. And I've listed some of these on this slide. The obvious ones are things like anticholinergics and opioids, but diuretics will decrease fluid in the person's body and therefore cause constipation, iron supplements, calcium supplements, and a whole range of other medications. One that's often missed in our patients is ondansetron. So patients may have been prescribed this to mediate nausea and vomiting from their chemotherapy or radiotherapy, and it is then continued as the antiemetic of choice, which is not good for somebody who no longer has that cause of nausea and vomiting and may have increased constipation due to their antiemetic. So assessment should include looking at all the physical symptoms, looking at doing an examination, determining whether the patient has abdominal pain, whether they have restlessness, headaches or confusion that can be caused by constipation. So therefore determining how much this patient's constipation is actually influencing a lot of other physical symptoms they may be complaining about. As I mentioned previously, it means different things to different people, and so we must take a very accurate history and ask a lot of questions of the person about their toileting habits. Past bowel issues are also important. Some people may have had constipation issues all their life and may take a lot of laxatives frequently right through their life, which is going to make treating constipation a little more difficult. It is frequently necessary to have examination, including an abdominal x-ray or a rectal examination, to try and determine how severe the constipation is, but also where the constipation is, whether it is high in their gut or low down in their rectum, so that we can choose the appropriate medication and route of administration to moderate their constipation. We frequently ask people to keep a bowel diary so they can keep a record themselves and actually start treatment regimens earlier rather than waiting until they are impacted and have severe pain and distension from constipation. Most of us will be familiar with the Bristol stool chart, and this is a very good way of being able to assess a patient's bowel action. It gives us an idea of what the consistency is and therefore the type of medications that might be appropriate to use for this person. We also have the Bowel Function Index, which is another very good tool that isn't just looking at the consistency of the fecal matter. It's also taking in a whole lot of other influencing factors. It is a validated tool that has been used in patients with advanced cancer and advanced disease. This tool is designed for health professionals to use. It gives tips so that we know what questions to ask, and we ask the patient to rate each influencing factor on a scale of 0 to 10. So we ask them about the ease of defecation, the feeling of incomplete bowel evacuation, and ask them to personally judge how bad they think their constipation is. When we're talking about management, there's a lot of non-pharmacological elements that we can educate people about and educate families about that will make a difference to their ongoing bowel habit. If possible, it's good to increase a person's fluids and increase their fibre intake. And fibre intake doesn't necessarily need to mean a big bowl of bran in the morning. It can mean taking fruit like kiwi fruit, oranges, orange juice, or eating prunes. We like people to increase their exercise and activity as much as possible within the constraints of their disease, but keeping active will make their bowel motions process through their gut much more easily. It's really important that we provide privacy for people. It's very easy in a busy hospital for people who are unable to get up and move for us to become very complacent and offering people a pan in the bed with no privacy, just a curtain drawn around them. If we can move that person into an area of privacy, that is going to be far more beneficial for them. And assist with positioning. It's very important that people are sitting in an upright position so that they are able to defecate in a normal way. Self-management is always going to be the best policy. People are normally fairly private about their bowel habits and don't want people interfering and asking them lots of questions all the time. So if we can encourage them to keep monitoring their bowel motions and keeping them at a healthy level, that's going to be far more beneficial for the person. And prevention is absolutely the best way to go. So if people are monitoring their bowel motions, if they understand preventative measures they can take using non-pharmacological measures, we can hopefully keep constipation at a much lower level. We also have pharmacological management. What we need to realise is that not all laxatives are the same, not all constipation is the same, and not all patients will respond in the same way. And unfortunately, we have limited randomised controlled studies to tell us which laxative to use and in what dose for what patient and what types of constipation. So we need to think about the types of laxatives we're using and recommend laxatives that are going to be most appropriate for the type of constipation in that person. So we have a list of traditional laxatives that we use, and I'm going to talk in a bit more detail about each of these. So bulk forming or fibre laxatives are the first type of laxative that we will discuss. These aim by increasing the bulk of the faeces in the bowel and therefore inducing peristalsis. It's very important when we're using a fibre laxative that the person is drinking a sufficient amount of water or fluids. If they just have the fibre laxative, that can form like concrete in their bowel if they don't take the fluid, because the fluid is what increases the bulk and the size of that fibre and therefore induces the peristalsis. These particular laxatives have a fairly limited role in palliative care simply because our patients generally aren't drinking enough fluid to make these a good option. The next group of laxatives that we have are the softeners or the emollients, and docusate is an example of this group. Basically, docusate is a detergent, so what it does is breaks down the surface tension of the faeces, allowing more water to enter into the faeces and therefore making it softer. This means that it makes it easier for people to pass the stool. We generally will use a softener with a stimulant as well, but in some situations a patient may only need to have their faeces softened, and so docusate on its own may be appropriate. Two major stimulants we will use are Senna or bisacodyl, and we have products with both of these available. We also have the Senna in combination with docusate, and that is probably our most commonly prescribed laxative. The idea of a stimulant is that it irritates the mucosa or the nerves and smooth muscle around your bowel and your rectum. It will increase intestinal motility, and people have always been very concerned about the development of tolerance to stimulant laxatives, but in fact, use and evidence does not seem to support this. However, if we find that a patient's been using a Senna laxative for a long time and they're no longer getting such a benefit, it's certainly worth switching over to bisacodyl or vice versa. There's nothing to tell us that one or the other is a more effective laxative, and so therefore whichever the patient can tolerate is going to be better. We do know that bisacodyl is more effective than placebo. We also know that these laxatives in some people can cause adverse effects such as bloating and cramping. So generally we will start at a low dose and titrate up to effect like we do with many other medications in many other symptoms. As I said, our most common laxative that we will prescribe will be docusate with Senna. We can also use docusate with bisacodyl, but it will mean using two preparations. We also have osmotic agents. The most common that we will tend to see is macrogols. We also consider lactulose and sorbitol to be in this group as well. The way these work are to draw water into the intestine, both the small and large intestine, and therefore, again, by drawing water into the intestine, they soften the faeces. Lactulose has been shown to be superior to placebo in chronic constipation, and it is a laxative that is frequently used in the elderly with ongoing constipation. It changes the pH of the colon, which also means that bacteria infiltrate the colon and break down the faeces, making it softer as well. Lactulose, however, we don't tend to use as much in, particularly in advanced disease, and that's because it can cause a lot of bloating, a lot of abdominal discomfort. So it really is a case of seeing how the patient goes, but it probably is not our first line laxative. Sorbitol is very, very similar to lactulose. It's a sugar moiety, which won't affect, however, glucose control in diabetics. The other laxative that we use is macrogol. For macrogols, it's very important that we mix the cellulose with the appropriate amount of water that is indicated on the packaging. because we need to make sure that we keep the product isoosmotic, because if we have too much of the cellulose with not enough water, it actually will mean that water isn't drawn into the gut. So generally we recommend that a sachet of Macrogol is dissolved in 125 ml of water. The other osmotic agents we use are by the rectal route. So that is things like our enemas that we have, either small volume or large volume phosphate enemas. These again work by drawing water into the rectum and the very lower end of the colon. They soften the stool and therefore induce bowel motions. These should only be used for occasional use and are used in the acute situation where patients haven't defecated for some period of time and are feeling particularly uncomfortable. Not all people will be happy with having an enema, and we certainly need to talk to people about that. They generally will work very quickly, however, which is a big advantage compared with most of our other laxatives, which will take at least 12 to 24 hours to have an effect. We need to be very careful, particularly when using high volume enemas, because they can disrupt a person's electrolyte balance and fluid balance in their body, and particularly people in advanced stages of disease can be very vulnerable to this, and of course causing electrolyte disbalance can make them feel very unwell. The other laxatives that are available are lubricant laxatives, so things like liquid paraffin or arachis oil, peanut oil. These coat the surface and make the stool easier to pass. They do have a significant amount of adverse effects though, and we need to be very careful when we're administering these. People need to be sitting upright so that the oil doesn't go into their lungs. They also will decrease the absorption of fat-soluble vitamins, and they can cause a leakage of oil through the rectum and make people have itchiness in that area. So lubricant laxatives are not something that we use commonly in palliative care, but we need to be aware that they're available for certain situations. For opioid-induced constipation, we have a product called methyl naltrexone. This is administered by subcutaneous injection. It is a peripheral opioid receptor antagonist, meaning that it blocks the opioid receptors in your bowel and gut. Preferentially, it doesn't have systemic absorption and so therefore will not interfere with the person's pain relief that the opioid is being prescribed for. They are indicated only for opioid-induced constipation. The dose is dependent upon the weight of the person. So if they are less than 60 kilos, they'll get 8 milligrams, and above that, they'll get 12 milligrams. They shouldn't be used any more frequently than every alternate day, and in general practice, they're probably only going to be used once and then are used again if the patient gets into a lot of difficulty and have not had their bowels open for several days. Need to be very careful that the patient doesn't have a bowel obstruction or a pending bowel obstruction, because these drugs could cause bowel perforation in that situation. So in summary, constipation is very common in palliative care. It's something that we need to address. We need to make sure that we're educating people about preventative measures. We need to recognise that it causes significant distress and consider it as a very important symptom to treat. Our monitoring and assessment needs to be very thorough so that we know what the person's talking about when they say they're constipated, so that we can initiate the right sort of therapy for that person. Generally, all patients who are prescribed an opioid will need a laxative as well, and they'll need that ongoing. The choice of the laxative should be appropriate to the type of constipation, and the doses should be started at the lower end of the range and increased until they have a good effect. Thank you for watching this presentation today.
Audio Jungle. Audio Jungle. Audio Jungle.